started. Good afternoon, everybody. My name is Megan Lowry. I am the Manager of Media Relations for the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us for this webinar on the report that was just released earlier today, titled Vaccine Risk Monitoring and Evaluation at the Centers for Disease Control and Prevention. You can now download a copy of the report and other supporting materials at nap.nationalacademies.org, and a recording of this webinar will be available on our website in the coming weeks. For those of you who are not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, engineering, and medicine. For each requested study, panel members are chosen for their expertise and experience, and they serve pro bono to carry out the study statement of task. The reports that result from the study represent the consensus view of the entire committee and must undergo external peer review before they are released, as did this report. So before we get started, I have just a few reminders. Please note that this webinar is scheduled to last 1 hour. So we'll start off with a presentation summarizing the report from the committee, and after they're done, we'll open it up to any questions you may have. To ask a question, just type it into the box below your video player that's labeled Slido, and you can ask a question at any time during the presentation. So now I'd like to introduce the chair of the committee, Dr. Jane Henney. Dr. Henney, over to you.
Thank you so much, Megan, and thank you all to the webinar audience for your interest in receiving our report today and its results. I have been privileged to chair the committee that has worked diligently over the last year and a half to produce this report. I am joined by several of the members of our committee. If I could have the next slide. These were the members of the committee. As you might imagine, we needed to draw on a wide array, a very diverse array of expertise as we approached our task. The members of the committee that will present today really are representing the full committee's consensus and report. And they are Dr. Perry Halkitis at Rutgers University, Sonia Hernandez-Diaz from the Harvard T.H. Chan School of Public Health, and Ola Yinka Shilanbula from the University of Michigan's College of Pharmacy. I'll now turn it over to Dr. Halkitis to start us off. Oh, I should review for you first our statement of task. This really guided all of our work, and you see the statement of task on this slide. We were asked to analyze all of the systems, methods, processes, and communication of a specific office in the CDC. As you're all well aware, the CDC itself is a very large, complex organization, but it has an office that performs all of the functions regarding risk evaluation and communication. And we were asked to do this during a specific time period, that time period of the public health emergency. We were asked not only to take sort of an after-action look at the performance of the office, but also to provide recommendations for how the office might function on routine basis and in emergency basis on into the future. So our task was twofold: to look at and analyze and evaluate the specific time period during the public health emergency, and then to be more forward-thinking in terms of what might be recommended for future change. I would now turn it over to my colleague, Dr. Halkitis, to relate to you how we approached our work.
Good afternoon, everyone. And so, as Dr. Heaney indicated, we were asked to assess the safety signals or risks and the methods used to detect those, and also to assess the robustness of communications. And in order to be able to accomplish that, we used multiple sources of information, which are listed on the slide in front of you. All of those sources came together to provide us with the information that we needed to make our recommendations and to draw our conclusions. Description of all of these are provided fully in the report. Next slide, please. Next slide, please. Oh, yeah, we're there. Thank you. So what you see in front of you are principles as we've defined them and are drawn from a report that was published in 2025 to report and frame the recommendations. We use these principles to undertake the evaluation required by the task. These principles are mutually reinforcing and they're co-equal principles, are equally important. They've stood the test of time as goalposts for statistical offices. These principles that we used, as I said, frame our recommendations, and they are adopted from the principles and practices for federal statistical agencies, which was published in 2025. To be clear, we are not advising that ISO be designated as a federal statistical agency. It is not necessary to achieve the committee's goal of vaccine risk monitoring and evaluation. For an organization that merits the nation's trust. But these are the principles that we use: relevance, credibility, data stewardship, continuous improvement and innovation, and independence to put forth the recommendations which we'll share with you during the course of our conversation today. Next slide, please. You're now going to hear about the two main sections that constitute our report. Chapter 2 on monitoring and evaluation, which describes and assesses how ISO detected, evaluated, and characterized vaccine safety signals. That constitutes Chapter 2. And Chapter 3, which focuses on how these findings were communicated to audiences, specifically to clinicians, policymakers, and the public. The committee saw these two chapters as tightly linked. Chapter 2, as I said, explains how ISO detected and evaluated. Chapter 3, how things were communicated. The shared themes between the chapters are clear: timeliness, as defined there, transparency, as defined in front of you, and complexity. Taken together, these chapters underscore that the detection, the evaluation of safety signals, and communication are interdependent pillars of vaccine safety work that is undertaken, and that strong science must be paired with effective dissemination to achieve its purpose. And now I'm going to turn it over to my colleague, Dr. Sonia Hernandez, who is going to review with you our findings from Chapter 2.
Thank you, Perry. Chapter 2 reviews ISO's COVID-19 vaccine risk monitoring and evaluation activities during the public health epidemic emergency and covers the 5 main systems utilized, cross-systems insights and gaps, key findings, and opportunity costs. Each of these systems did something different. They had different strengths and different limitations. And together they form a safety net to catch and evaluate signals. Some of them were in place at the time of the public health emergency. VERS collects any adverse event and report from anyone and helps detect early signals. But it is a passive surveillance activity limited by selective reporting and lack of controls. Therefore, it cannot prove cause and effect. VSD uses electronic health records from millions of people and compares risks between vaccinated and non-vaccinated, but it may be slower for identifying rare outcomes. And CISA is a network of experts that review complex cases, but at a small scale. Other systems were implemented during the emergency to enhance vaccine safety monitoring, including the vSafe. That was an online registry where participants reported how they felt after vaccination, and it helped identify common reactions, but was limited for rare events. And the pregnancy registry that enrolled and followed thousands of women vaccinated during pregnancy and recorded maternal and infant health outcomes, but was limited by a lack of reference group, for example. Used together, these systems have complementary strengths and allow for early detection, robust risk estimates, expert review, and real-time participant feedback. Their combination created a solid system for vaccine risk monitoring and evaluation, which was integrated with efforts at other federal agencies in the US, such as FDA, CMS, the VA, and IHS, and complemented by findings from systems in other countries. However, some gaps were also noted, including fragmented presentation of findings and a lack of central dashboard for harmonized reporting of risks. The myocarditis case illustrates how these resources work together to provide a comprehensive picture of vaccine risks. VAERS detected reports, VSD quantified the risk, and CISA reviewed and described cases, and VSafe captured symptoms and pointed at potential patterns. These systems identified and evaluated a wide range of adverse events. Some were pre-specified outcomes, such as anaphylaxis or myocarditis, but non-pre-specified events were also collected. And most reported adverse events were non-serious, such as local reaction. And in the report, you can find summarized the main signals, as well as reassuring findings, such as pregnancy outcomes or mortality. Overall, the coordinated use of all the systems led to a comprehensive, near real-time evaluation of both rare and common events. However, we noted some opportunity costs. Focusing resources on high-priority signals like myocarditis improved timeliness, but came at the cost of other investigations, some of which were of public concern, for example, tinnitus. While this may be well justified, the lack of transparency about which signals are investigated and why can reduce public trust. Similarly, the protocols for how signals are prioritized were not publicly available, and the long-term scientific agenda of ISO was not articulated, creating this perception of a black box decision-making process. Now, framing our observations within the principles presented to you earlier, we observed that ISO's monitoring was responsive to urgent needs, but lacked a visible strategy, and that the relevance can be improved by transparent processes and by inclusion of stakeholders. Robust methods were used and findings were shared, but the lack of harmonized reporting of risk estimates and no central repository undermine clarity. So we think that credibility can be improved by standardizing communication and organizing summaries more clearly. ISO protected the privacy of health information, and as a result, access to individual health data from some systems is difficult. And we think that generation of evidence may be facilitated by continuing to explore ways to make vaccine safety data more accessible while maintaining confidentiality. ISO innovated rapidly with tools like VSafe, and this continuous innovation will require sustained resources beyond the emergency, structured evaluation and integration of new methods and technologies, and federal coordination. And finally, pandemic communications sometimes blurred safety monitoring with vaccine promotion, and the perception of independence can be improved by a clear separation of ISO analysis from vaccine recommendations. I will now pass the microphone to Olayinka.
Thank you, Dr. Hernandez-Diaz. So now I'm going to talk about the communications, which is in Chapter 3. In medicine and public health, we acknowledge that risk-benefit perceptions and health behaviors are shaped by varying levels of trust, health literacy levels, and the ability of individuals to be able to follow guidance. We also know that communicating effectively, especially when it comes to clear, consistent, understandable information, can be especially difficult when there are a couple of scenarios. First of all, when there is constantly evolving knowledge about an emerging disease like COVID-19 was, and also when there is limited understanding of the scientific process. A second scenario is when there is new authorization or emergency authorization on newly licensed vaccines, and also at the same time, we are having misleading information that is widespread. And then third, when the vaccine recommendations are changing based on updated scientific knowledge. One of the things that we also acknowledge is that there are challenges when it comes to communicating vaccine risk data. For example, vaccine data are usually presented as a risk to a population, which makes it challenging since many individuals want to know how the data is specific to them. However, vaccine risk data cannot provide individual-specific risk information. We also know that it's a challenge because it takes time to obtain and be able to analyze data, especially if it has to be reliable and valid. We also know that it's a challenge because risk and benefits are not the same for everyone, and our understanding of risk and what we know improves over time. Vaccine risk data are also complex, and there is the tendency to use technical language versus the use of lay language. And when there's some scientific consensus about vaccine information, we acknowledge that it doesn't always guarantee that the public is going to trust it or accept it. And like I already mentioned, there is misinformation that is widespread about vaccine risk information. So during the COVID-19 public health emergency, the communication was challenged by, first of all, public's unfamiliarity with the emergency use authorization process. There were concerns about vaccine safety and new technologies such as mRNA. And also we saw declining trust in authorities such as the public health officials. There was also widespread misinformation, especially on social media. And the last challenge is the individual's personal beliefs about the risk of the disease influenced their decision on whether they wanted to get vaccinated or not. So now I'm going to talk about what our committee did in our assessment of CDC's external communications and ISO's communications integrated into this. So we did an in-depth review of various web pages because, first of all, they were publicly available, and they were the main method of communication to our three key priority audiences that you already heard about, which is the public, the healthcare professionals, and our policymakers. Our evaluation of these web pages fell into at least one of these three, whether it was related to a safety system, whether it was related to a safety signal, or whether it was related to general vaccine safety. In our evaluation, we considered what are effective communication strategies, and on this slide, you see a couple of those. First of all, we consider things like, did they avoid or appropriately use technical jargon? Did they define new or key terms in a way that the target audience could understand them? And when they were defining these new terms, did they use brief and clear sentences? And also, did they all clearly communicate the science upon which whatever information they were communicating was based on? So now I'm going to talk a little bit more about our observations. First of all, we noticed that there was an assumption that the audience had a baseline level of knowledge about this vaccine risk information. And we acknowledge that technical audiences are usually not experts when it comes to communicating risk. And it is beneficial to use plain language with explanations that will be accessible to the audience, and even using technical concepts that are accessible irrespective of what the audience is. We also noticed that there was a lack of consistency in the use of definitions of key terms. So, for example, safety signal, safety concern. These were not defined at all, and there was a lack of consistency when they were used across content. And in some ways, they were also used without context. In terms of specificity of the risk language across the materials, we noticed that in some cases they were defined in a numerical way, and in some cases they were described in a qualitative manner. Our next observation is about the accessibility of the information. We observed that some of the web pages did provide appropriate safety information to these technical audiences, but it needed more information that was robust, that clearly explained the science upon which this information was based on. In some cases, there was context, but it was limited, and explanation for certain statements, such as for a most intensive safety monitoring in US history. Now, we acknowledge that when claims like this are made, there needs to be evidence to support it, especially because we know that the public is resistant to the use of this type of blanket statements. Our next observation is how it was structured and organized. We noticed that there were difficulties in navigating these web pages because a lot of those web pages had similar content. And this can be a challenge when users are trying to navigate this effectively and be able to recall what might be key information. Now, one note that we would make is at the time our committee did our assessment, there was no clear delineation on who the content was intended for, whether it was a technical audience or whether it was a lay audience. However, as at May 15 of this year, we did see now that there is now clear delineation with clarifying labels on who the message is intended for. So to be able to build trust, we acknowledge that the landscape of vaccine safety data is nuanced. And so we observed that a few of the web pages needs to provide information to trusted lay messengers so that they can be able to communicate vaccine information about risk in a way that is effective, which is especially critical for our historically underserved and underrepresented groups. Now, when I say tailoring, this could be two forms, for example. It could be providing risk information to a specific group, or it could be providing messages in a manner that is culturally responsive to a specific concern. When it comes to communicating with the public, we noticed that most of these communications also remained as being one-directional. There was no mechanism to be able to then get real-time bi-directional engagement with the public. And so we observed that as communication expectations evolve, the CDC and ISO should begin to explore these new formats, such as the use of multimedia summaries or Q&A forums, to be able to then communicate this complex vaccine safety data. And now I'm going to turn it over to my colleague, Dr. Alkides.
Hello again, everyone. So in a couple of moments, we're going to get to our conclusions and our recommendations. But before we get there, we wanted to share with you some cross-cutting themes. Next slide, please. The first is the set of lessons for ISO that we developed from our data collection with regard to the public health emergency. And there are three lessons that we came up with, that we developed. Number one, the need for ISO to have a clear mission and strategy, recognizing that a long-term plan would be able to effectively guide priorities and resource allocation. Number two lesson, that there are communication challenges, and that each system for detection is designed to characterize different risks, different adverse health outcomes, different population. So that's one challenge, communication. The other challenge is translating all these complex data that are very technical in nature, but translating them for both technical audiences, but also for public audiences in a way that is consistent, because we found that they were inconsistent. And third lesson that we developed was that there's no single ISO voice, in quotes, on vaccine risk. And what does that mean? What that means was ISO was not consistently identified as the authoritative source of vaccine risk information on CDC's website. So those three lessons are critically important. Next slide, please. In addition, we'd like to, in terms of our cross-cutting themes, put out there to you a set of strengths and current limitations associated with each strength with regard to our information gathering. Strength number one, there is a robust monitoring network. However, the infrastructure remains fragmented across the various systems. Number two, there's rapid signal detection and response. However, the prioritization of signals lacks transparency. Number three, there are very credible science and risk estimates, but variation in those estimates across the systems creates confusion. Number four, there's a strength with regard to reassuring data on vaccine risks. However, detecting rare events in the system is difficult. Next, there's strength in timely updates through expert public forums. However, there are communication gaps and the use of technical jargon that does not always translate to broader audiences. Another strength is the flexibility that we found. It was the flexibility in adopting new tools like vSafe. However, while it was adaptable this time, there's a lack of a clear long-term strategy in this regard. And finally, strength, there were integrated efforts across surveillance and public outreach, but there is a need for clearer delineation between risk monitoring and policymaking and promotion. A clear delineation between those elements. Next slide, please. So, based on our work, based on these cross-cutting themes that I just shared, we offer a set of 3 conclusions and a set of recommendations, and each recommendation is supplemented by implementation steps. Let me start by giving you conclusion number 1. Next slide, please. Conclusion number 1. ISO has played an important role in performing and communicating about rigorous vaccine risk monitoring and evaluation. We determined, our conclusion is that ISO had a significant role in performing these tasks. Conclusion number 2. In response to the public health emergency for COVID, ISO staff and systems produced and communicated large amounts, a large quantity of timely, important, high quality monitoring, evaluation, and communications about COVID vaccine risks. Large amounts of information that was important, that was high quality, and that was communicated. Third one. The third conclusion is the following, that, and I'm not going to read this directly, but I'll frame it for you. The work of ISO was also intertwined with other CDC efforts and other governmental efforts to foster vaccination. And by that, we mean that there was a conflation of efforts of ISO with other entities of the CDC and of other governmental agency, which leads to a lack of independence and an inability to share information to the audiences of interest, namely health professionals, policymakers, and the public. So the credibility of vaccine risk information that is produced by ISO is affected by this intersection due to the fact that ISO lacks the organizational independence and resources to be able to disseminate its information to the 3 audiences that we're talking about: health professionals, policymakers, and the public. Next slide, please. I come back now to the principles that I addressed earlier and that I put out there for all of you earlier. The 5 principles: relevance, credibility, data stewardship, continuous improvement, innovation, and independence. Again, I remind us that these were adopted from a report. These are mutually reinforcing principles. They are co-equal principles, and they have stood the test of time as goalposts. So right now, I'm going to turn it over to my colleague, Dr. Haney, who is going to go through our recommendations in light of these principles that we use to frame them. Thank you, Dr. Haney. Oh, is it still me? Oh, yes, it is me. I apologize for that. I apologize. So this final slide that I've been asked to share with you, it reinforces the idea of the three audiences that we were talking to, namely health professionals, policymakers, and the public. And the committee directs the recommendations you're about to hear, which I spoke to early that my colleague was going to take over, for the future of vaccine risk monitoring and evaluation, but intends to encompass the staff and the systems of ISO. And in the report, you're going to hear us using the term risk rather than safety, as safety has different meanings for different audiences. So again, let me say the approach to the recommendations. Using those 5 principles, the committee directed its recommendations for the future to a vaccine risk and monitoring evaluation office, but intends that it encompasses the staff and systems of ISO. And you're going to hear Jane speaking about these recommendations with regard to risk rather than safety. And now I believe I'm going to turn it over to my colleague, Dr. Haney. Yes, I am. Thank you.
Dr. Haney, I believe you're muted still.
All right, beyond our technical difficulties here, I would like to say that before I start the recommendations, I'd remind you that the committee evaluated what was done by the ISO staff during the emergency. You've just heard that presentation from my colleague, the conclusions we reached, but many of the recommendations are the forward thinking of what should be done based on this going into the future, both the routine activities of the ISO office and with respect to future pandemics. I would also say that as we start into the recommendation sections, 4 of them are directed to this office. One of them is directed, the last one is directed to the CDC because only they can be, are in a position to enact the implementation step. But with respect to relevance, clearly the first order of business for this office is to develop and make public a strategic plan. We believe that it should have wide input from health professionals, policymakers, and the public, both to assure that the plan is scientifically sound, but that it will also meet the needs of those who are going to use the information and really articulates the office's role in monitoring, evaluating, and communicating vaccine risk. This office, as you've heard, exists. It's performed admirably, but very few people other than those who use it or are familiar in this particular discipline are aware of the elaborate nature of these systems and their usefulness and importance in terms of monitoring and evaluating risk. So developing a strategic plan that includes a clear mission statement. We believe that very strongly and recommend that there be established a board of scientific counselors for this office. Boards of scientific counselors would not be unique. They are widely used across a number of public health agencies and including other offices within CDC. But their involvement could also be helpful in terms of the development of the strategic plan. I'm going to speak to the composition of this board and its other responsibilities in future slides. So this particular establishment of a board was of a high importance to our committee in making this recommendation. Third, a part of that strategic plan would also include a strategic agenda for risk monitoring and evaluation. And with the board again to look at mechanisms whereby bi-directional communication with health professionals and the public could be made even more effective. And 5, that the plan would serve not only for the routine operation, the day-to-day operation of the office, but also outline how it might act in a public health emergency. We do know that during COVID, and appropriately so, the office really became part of a larger task force that was formed across the agency. But that kind of change that would happen during an emergency just ought to be noted within the context of a strategic plan. With respect to the Board of Scientific Counselors, we believe each member should be widely recognized and have an established track record and expertise in one or possibly more of the following fields. We believe that all of these disciplines really would bear importance to bringing their expertise to this table for discussion. The responsibilities we think that the board should have would be to help in the development of the strategic plan, as I've previously noted. The board should review and comment on the adequacy of resources for the office, both its budget and its staff, because we do know resources are needed, and particularly during times like the emergency situation. Thirdly, the board would serve as a conduit of communication for health professionals and the public. Fourthly, their advisory function on the scientific and processes of monitoring and communication, and also overseeing to make sure that the office does retain this attribute of independence and stays clear of policymaking and vaccine advocacy. We do know that there is another unit within CDC, the Bureau of Health Statistics, that long has had the practice, because it is a statistical agency of government, to providing data to which they turn over and others make policy based on that. We are not recommending that the ISO office become a formal statistical agency of government, but we do believe that that way of operating, of developing scientifically strong and useful data that then can be used by policymakers or others would create a model for use here. And last, the board could be involved in additional responsibilities that come in other recommendations that this committee made. Next slide, please. Related to credibility, we believe the keywords here are transparent and comprehensive. As I mentioned before, this office is vitally important in what it does. But it is a part of a very large and complex organization. Having the public and health professional publics have more visibility into what it does and that it exists and how it goes about its work. Communicating that we think is vitally important. To implement that, number one, coming back to this principle of this is the office that provides information about risk related to any individual vaccine and evaluates risk. And so focusing on that rather than getting into policy making and promotion is a very strong implementation step here. Not that they have in the past, but the perception that that might not be the case makes this even more important. Secondly, developing a portfolio of public information to explain these systems and methodological approaches that you've heard so much about from the speakers today. What the data sources are, their strengths and limitations, how the office sets priorities. That always is helpful in people understanding exactly what is going on in the office. Thirdly, again, this speaks to public availability of the protocols that are used, including changes that are made during data collections or during the analysis of data and why those changes are made. Fourthly, developing and disseminating very plain language summaries of vaccine risk. As you heard before, that was one of the limitations that was found, and we think that into the future that needs to be addressed. And fifth, to standardize risk reporting across communications and where available by risk groups. Recommendation 3 has to do with data stewardship, a very important issue. This office has been and needs to continue to be a good steward in the monitoring and evaluation process by protecting the vital information and the privacy of individuals and really honoring their participation in these studies. Our implementation steps here are to protect the personally identified information using the appropriate standards. This has been done in the past. We want to emphasize that that practice needs to continue. Secondly, to solicit input from researchers and the public about key elements of the research agenda, getting that input early so it can be incorporated into the forward thinking of what is done by the office. And thirdly, to explore ways in which the vaccine risk monitoring and evaluation would be more transparent, and where feasible, where the data that it has been used for ISO to do its study, where it's feasible, be able to make it available to external researchers as well. We know that this needs to be done with great care. It probably is something that the office will need the advice, support, and oversight of the Board of Scientific Counselors, but we think this is worthy of exploring. And recommendation 4, continuous improvement and innovation. like all organizations, none should remain stagnant. So really being quite concrete about ways in which these systems can be continually improved and how innovations will be incorporated will be another key to success. Implementation steps here. One would be to develop metrics for evaluating how the strategic plan is laid out and how what metrics will be used to evaluate whether it is successful or not. Again, getting this done with the advisors would be an approach that we recommend. Second, maintaining the current systems, but incorporating advances always that come out of informatics, vaccinology, epidemiology, statistical methods. This has to be an ongoing process. And thirdly, the important work that's being done in risk communication and using research in that area to constantly inform and assess communications about risks that are identified, monitored, and evaluated by this group would be part of our recommendation. Now, the last slide, or the last recommendations, will really have to do with independence, that being free from undue internal or external influence. And we have spoken a bit about this in other parts of this presentation. But this is really directed to CDC, who has the ability to assure this, and that is to protect the scientific independence of this office, to provide it with the needed administrative support and financial resources it needs to do to conduct its activities. And both of these are very essential steps. The first probably speaks more to continuing to have an office that can be that continue to be trusted for the results it gives, but it needs to be supported administratively and financially so it has the ability to conduct its work. Our implementation steps here, again, this whole issue of keeping it out of the activities of policy making and promoting vaccines or vaccine advocacy. Secondly, increasing the awareness of vaccine risk monitoring evaluation work and clearly distinguishing that from the work that is done in the policy context that speaks to increasing immunization. And third, to permit and encourage prompt publication of risk data. All of this will require resources, which CDC can address as well. But those would be our implementation steps with this. I want to say one more word about independence. Independence means just that. It means being insulated. It doesn't mean being isolated, because it still is going to be very important going forward, just like it has in the past, for this organization to interact effectively with other agencies such as FDA or other international agencies that also work with respect to risk and evaluation issues or other elements of the federal government, but it still needs scientific independence to do its work, even though it is oftentimes working and coordinating with others. We do believe that consultation, collaboration is a very strong and vital thing and needs to be fostered. But the final decision-making around monitoring and evaluation of vaccine risk information and the scientific content of that risk communication needs to clearly remain with this office and be articulated in that way to the many audiences that need this kind of information. With that, I will turn it back to Dr. Halkitis.
Hey again. Good to see everyone again. And let me just conclude with some big ideas from the report to bring us home. And the first big idea is shown here, and it is as follows. The committee believes that if we want to increase the use of vaccines when they're indicated, and therefore the benefits of vaccination, we need to increase. One way to do that is by increasing the understanding and increasing the confidence in the studies of risks that are conducted by the federal government. And in that regard, if we believe that to increase vaccines use and therefore its benefits is important to increase the understanding and confidence, we believe that ISO merits the nation's trust in this regard. And the work that they have done merits the nation's trust. Number two, next slide, please. We also, however, recognize that the work of vaccine risk monitoring and evaluation and communication, all those tasks could be bolstered, enhanced by adhering to the 5 principles that we shared and which framed our recommendations. How do we do that? Well, implementing that will require resources, no doubt, but also the commitment of the CDC director to protect the office in order to significantly enhance the capability to deliver timely, trustworthy, and scientifically robust vaccine risk information. So we would like, we write in the report about the idea of enhancing the work based on these 5 recommendations, but we need resources and we need the CDC director to protect the office. And in order for this to happen, and that has to happen. And then finally, we believe that if we do this, it will lead to increased public confidence in vaccination programs, ultimately contributing to stronger public health outcomes and preparedness for public health emergencies. Jane, bring us home.
Jane, I think you're muted.
Sorry, unmute. Thanks to the panel for your presentations. Thanks to all of you in the audience for your attention and interest in this subject. I think that we can open it up for questions, and Megan is going to lead that.
Great. And just a reminder to our audience to ask a question, just type it into the box that's below your video player labeled Slido. All right, our first question is any consideration being given to having the Board of Scientific Counselors include some representative of the communities of the public to ensure multiple levels of communication from scientists to the lay public?
Oh, this is, our recommendation is for a Board of Scientific Counselors. And we believe because many of these meetings will be held and open to the public, that there would be ample time for public input on a variety of subjects. And we think that that would be welcome and helpful. But we did not come to the conclusion that all of that knowledge or expertise might be resident in just one member on the committee. Of course, and as these boards are composed, that might be given a secondary consideration. But the committee recommends a board of scientific counselors at this point, with holding many sessions open to the public and for public input.
Thank you. Our next question is, the committee discussed the value of understanding public concerns as they emerge. What opportunities do you see for ISO to strengthen two-way communication so that it can learn from people, the public, in real time and ensure safety information reflects what people most want to know?
I'm going to turn to my colleague, Yinka, if you would respond to that.
Yeah, thank you for that question. One of the things that we talk about in the report is for an opportunity for the ISO to be able to have open forums and Q&A forums so that bidirectional communication can happen with the public about vaccine risk information. And so that is an opportunity to enhance that mechanism that would then allow for that free-flowing information that is now allowing for the public to be able to provide that input and also for ISO to be able to respond as well.
Wonderful, thank you. Our next question is, can you share a specific example of how post-vaccine surveillance data from the sources you have mentioned was analyzed to establish a causal link with an adverse event that was not identified in the initial COVID-19 vaccine clinical trials?
Dr. Hernandez-Diaz, if you would respond.
Yes, I think some of the adverse events of special interest were added as we were gathering more on the vaccine and incorporated to make sure that we were gathering that information. So I think the specific thrombosis that were identified were added and targeted as a special adverse event of interest and a signal to be more closely followed.
Great, thank you. All right, our next question is, and we have about 2 minutes left, so this may be our last question. If the committee has any last notes they want to share. How can CDC/ISO help the public better understand and trust the information that these systems and databases produce? And what improvements might strengthen their ability to detect unwanted effects?
Well, I will ask my other colleagues to chime in, but I think one of our findings here is that this office does extraordinarily good work. Very few people know about it. So I think looking for ways in which this office that functions so well on behalf of all of us in terms of identifying and evaluating specific risks regarding vaccines, that could be uplifted. All too often, I think that you're working along, you're in a smaller organization, and your message may not get out as clearly and as concisely as it needs to in order to appreciate, at least on my part, at least, that all of these systems really work very well on all of our behalf. I think that's what we're asking for here. More visibility for this office so people really know that it exists, not as an office, but as a office that houses tremendous wealth in terms of data systems, the ability to monitor them on all of our behalf. So more visibility for that, and more voice in terms of amplifying exactly what the office does in terms of identifying and monitoring and evaluating risk of vaccines.
And if I could just add very, very briefly to what my colleague said, look, I want to underscore one of the big points, which was that ISO merits the nation's trust. You know, during this crisis, during this public health emergency, large amounts of data from multiple sources of data gathering, you know, came together to inform the public about, you know, the risks associated with vaccines and to put the information out there in a pretty timely manner. As with any organization, of course, we put forth some recommendations that can improve, you know, this work. But the work that was done merits the nation's trust, and and this is what then merits the visibility of this entity to do the work that they're doing. And it's because of the quality work that they're doing that we're also reinforcing this idea that we need to enhance their visibility in continuing to do this work.
Great. Well, thank you both for those closing thoughts. Unfortunately, it looks like that is all the time we have for questions today. So I'll just again note for our audience that you can download a copy of the report for free and in full at nap.nationalacademies.org right now. And you can access a recording of this session on the National Academies website in the coming weeks. So with that, I'd like to thank our speakers and thank you again to our audience for participating today.